Okay. Hello, everyone. Thank you so much for attending my presentation. Today, I'm going to be presenting on Alteplase and how you select the right candidate for this medication. My name is Ijang Ngando. I am a medical student at Columbus Central University School of Medicine, and I have been blessed to have worked with Dr. Bernard and Dr. Stein for the last month, and this is my final presentation on a topic that pertains to neurology. For this presentation, I've got nothing to disclose. And so my objectives are to discuss the relevance of an acute stroke within the neurological setting, as well as, obviously mention different types of strokes like an acute stroke and mention the key differences in how patients present with this. I'm also going to highlight two key clinical trials that have led to how we choose patients that can get treatment for this medication. And most importantly, I'm going to talk about treatment options and how we manage patients in the event that things may go wrong. And I'm going to highlight a case that I actually was part of when I worked at the hospital a couple of weeks ago. So a little background. So stroke is known as the second leading cause of death worldwide, and majority of our patients that have disabilities tend to be within this community. Both men and women have a risk of having a stroke. A lot of times I always say that strokes can occur in either the young or the old, but for the most part, once you're 25 years old or higher, you have a much higher risk for that. And also your East Asian, Central and Eastern European population tends to have a much higher propensity as well to develop this. There are two types of strokes. You have your ischemic and hemorrhagic strokes. So I always have it called a bleeding and a non-bleeding stroke. Ischemic stroke usually pertains to a patient having more of a blood supply obstruction, and hemorrhagic is more of a bleeding stroke where the blood vessels rupture, and this can lead to, spilling of blood into the intracranial cavity. Ischemic strokes account for about 60% of all strokes, and you have your intracranial cerebral hemorrhage, which is about 28%, and your subarachnoid is about 10%. The one thing I want you guys to realize is that you can go from having an ischemic stroke, which is a non-bleeding stroke, to having a hemorrhagic stroke within that time frame or sometimes. So it's important that as we care for these patients, we watch them closely and ensure that we don't get to that point. And even if we do, it's detected early. And that's just what I want to highlight below. And so here's just a picture that shows you of the two main types. You have your ischemic stroke, which again, I mentioned it's more of a blood supply, obstruction of blood flow obstruction to your left-hand side. To your right is where you have a hemorrhagic stroke, which has more of a bleeding, and it tends to be associated with ruptured blood vessels that leak into the brain. And of course, ischemic is more common, as I mentioned, and hemorrhagic stroke usually is going to be one that requires more invasive treatment in the event. Like in these cases, patients have to have neurosurgery involved, as opposed to an ischemic stroke where we can use a medication, which I'll talk about, to treat our patient and prevent them from converting to a hemorrhagic stroke.
Yeah, look.
And so risk factors for stroke. So one of them, there are two main categories. You have your modifiable, which are things that we can control, and then the ones that are non-modifiable, which are things that we cannot control. During my time as a student, we had a patient last week that had a stroke last year, and we mentioned a couple of risk factors. I talked about that with Dr. Bernard. So a few things that we can control as patients are blood pressure, whether it's, your salt intake, being on medication. Obesity, your weight is obviously a big factor. Physical inactivity, making sure that we exercise. A poor diets can also be controlled, and smoking are a couple of things. And again, what I have noted on here, it's not an inclusive list. There are other things that one can be exposed to, but I wanted to just, highlight the more common things that you may come across. Your non-modifiable factors are things like your age. As I mentioned, stroke does not discriminate. We had a patient that was in the clinic, I believe it was 3 weeks ago, that had a stroke at the age of 2. And then you had another one who came in and he was also in like his 70s and he had a stroke. So it can be any age. Obviously, your history and genetics can have a huge factor. And other things like sleep apnea and migraines and headaches are things that, we need to also remember can increase patients being at risk for a stroke. one's race, African American being Black, American Indian, Hispanic adults, and then we've seen that men have a much higher risk of getting a stroke than women. So how do they present with a stroke? So many of us know about, FAST, which is, your face, looking at the face, arm, speech, and time. But I like what they call BFAST because BFAST accounts for two things that we tend to appreciate in a neuro exam, but it's not really one that, is impressed upon us when a patient first comes in. So BFAST stands for B being like, looking at one's balance. And then also the eyes, looking at their eyes, is there any blurred vision? And then your normal fast, look at the face. Do they have any facial drooping? Their arms, is there any like, weakness in one side or the other? One speech. And then also the time, obviously, is crucial, whether it's a time from when they were last known to call, the time from when you call 911, time is of essence throughout this entire process. A couple other things, again, against like
Just got it. I clicked on got it.
Got it.
Yeah, it was just.
With
Is there something on there?
in either of the eyes, whether it's blurred vision in one eye or the other, trouble walking, so balance, the coordination, and having a serious.
Sorry, okay. You got a problem here with your sound. I'm not sure what happened. Can you sign in? Wait a second.
Okay.
Yep.
So for the next part of my presentation, I'm going to talk about the history and physical of an assessment in a patient that presents with a stroke. So obviously, many of them may present in a clinic, but most of the time it's in an ER setting, such as my case that I'll talk about. So in this case, you want to make sure that from when they leave their house, wherever they're at, to the hospital, everything is done very quickly. Within 3 hours, within an hour at most, it's ideal. You want to conduct a focused history and physical exam. So you can't, you need a very focused exam allows you to get to the point of, concern and address things before a patient is outside of the window for when they can get certain medications. There are three main conditions that can mimic a stroke. So as a future, resident or, practitioner, it's crucial that you exclude these from the get-go. So a patient comes to your ED and they tell you, oh, the patient may have a stroke. You want to make sure you ask for a finger stick. It could be a hypoglycemic event, something as simple as that you can correct with, D50 or, juice. A patient having a seizure that could be in the post-ictal phase and that could resemble stroke. So getting a history from, loved ones or those around is essential. Migraines as well can also, be a potential stroke mimic. And again, you want to understand the etiology of the stroke. So you want to know, is a stroke a bleeding stroke? Like, did they have any like an eruption of blood vessels? Did the patient have, did they have, a non-bleeding as like an occluded, vessel, or is it a subarachnoid hemorrhage? So knowing the etiology is crucial. And a lot of this is done via imaging studies that we'll talk about later on. So I just have, a very comprehensive list of other conditions that mimic stroke. And here, you have your metabolic, causes. I mentioned here hypoglycemia. Werner case also could be another thing in your alcoholics. And then, just hypoxia and, any mitochondria illness, which you don't really see as often. Infectious conditions could be like Bell's palsy, which is a big one, which I have seen. Could be a CNS abscess, a patient having a CNS, let's say meningitis of some sort. That is, quite severe. Neuro causes could be a brain tumor, traumatic brain injury, migraine with an aura, multiple sclerosis, and then you could also have toxins that can actually, cause patients to have these. So even though it's a fast, neuro exam or check that you want to do, a focus exam, you want to make sure that you cover these general categories before you proceed to the next step. And so hypoglycemia is commonly seen, as well as seizures post-ictal phase. So with your neuro exam, there's 6 main things that you want to focus on: the cranial nerve examination, which you're going to look at the vision, eye movements, facial sensation, facial expression. their hearing, their taste and swallowing. You look at the muscle strength, their tone, and and again, I mentioned that with some patients, they may have, weak arm on the right side versus, versus the left side. You want to check their reflexes, check for coordination, sensory function, and then the gait and postural examination. All of this is done like, looking at your neuro exam check. And this is usually done by the nurse as well as neurology when they consult with the patient and the ED attending, of course. And ultimately speaking, you want to obtain a score which we call your NIH Choice Scale score. So NIH is the National Institute of Health, and this score essentially, goes over 11 categories. And with these categories, you're able to get a score. And the score tells you the severity of the stroke. So your score can range from 0 to 42 points. The higher the number, the more severe the patient is. A score of usually 21 to 42 indicates a very severe stroke. With thrombolytics that we'll talk about, usually patients have a score of 28 or more, and that usually allows them to meet criteria to receive the drug. So with your ED workup for stroke, I mentioned here, the key thing here, again, time is of essence. A lot of hospitals that are stroke, stroke centers have, what they call, your ideal goals time-wise. So from when the patient gets the door to seeing the physician, it should be about 10 minutes or less from when the stroke team is alerted. So as a pharmacist, I'm part of the stroke team. It should be within 15 minutes from when they get to the hospital, the ED, or the door, wherever they're at. From when you get a CT or MRI initiated, it should be within 30 minutes. And again, imaging is done to ensure that the patient, we know if the stroke is, the etiology is either, ischemic or hemorrhagic in nature, and that governs how we're going to treat the patient. You also want to make sure that we have IR or, radiologists present to give you a preliminary interpretation so you can make, a very time-sensitive decision as to what the patient needs to receive. And then obviously, your time for when a patient needs to get neurosurgery involved for, let's say, hemorrhagic, intervention is about 90 minutes in most places. So to your left, I have a few bullet points just to highlight all that I mentioned from the picture. So again, you want to know your last known wall time. If a patient comes to your ED and they say, oh, we think they have a stroke, you want to ask the patient if they can tell you, or a caregiver or whoever's present, when were they last seen normal? And it's crucial because, again, you have a time frame or a window for when a patient can receive a medication. So you've got cases where a patient comes and they're like, oh yeah, I last saw my mom, she was taking a nap. In that case, there's so much uncertainty that you don't even want to take any chances. Therefore, you just don't know when the last known wall time is. If they tell you, oh, my father took a nap around 3 p.m. and now it's about 5 p.m. I noticed when they woke up, it was a 1 hour nap. They appeared okay, but then all of a sudden, they couldn't speak, they couldn't lift their left arm. Then you have 2 hours, from when they were last seen normal. So all of that is so crucial, and I will explain why later on. You want to get a CT scan done. CT scan is quicker, and you get enough information to determine if the patient has a bleeding or non-bleeding stroke. But an MRI will be needed to get more information later on in the process. But again, at this point, you want to get things quickly. You also want to get a medical history. Hopefully, they've been to your hospital before or your clinic, so you can kind of look at that information. Things as like if they had a stroke in the past and what happened, do they have any baseline neuro deficits? Because again, that could also be a concern, because of a patient, let's say if a patient was high functioning and they were independent before they came to you, and then all of a sudden they're having all these deficits, and it's different as opposed to somebody coming from, let's say, a SNF, a nursing home, skilled nursing facility, where they were already getting assistance and now they're here with you. All of those things I think you need to account for. Do they have any baseline dementia, Alzheimer's? Because again, that's going to affect their neuro exam and their scores. All these things can mask one score, and so you want to make sure you get the information. It's crucial that you also do a fairly thorough medical reconciliation. You want to know what meds they're on. The key things here, again, antihypertensives, blood pressure is going to be a big thing, as you will see in the presentation, and then also blood thinners. Blood thinners from anything from aspirin to warfarin or Coumadin to Eliquis, your neuro-oral anticoagulants. Any of those are crucial for you to know, not just for you to know what they take, but to also know when they last took them is crucial as well. So there are two main trials that were conducted in the past to justify our use of a thrombolytic agent. And I would say up until the last maybe 3 to 4 years, Alteplase or tpA was your go-to for the management of an acute ischemic stroke. And so we call these clot busters thrombolytic agents. The two trials are your NINJ trial and your ECAS-3 trial. And I just have these here, but I have quick summaries of the key findings with each one. With your NINJ trial, it just showed you that efficacy and safety of tpA must be given within 3 hours from the onset of symptoms, so from the last known well time. And then with ECAS-3, it showed that we could possibly extend the window from 3 to 4.5 hours of onset, but other things need to be accounted for, which I will kind of highlight in the next slide. So here to your left is the IA criteria for the NINJ trial. So in summation, you can see that, patients in the NINJ trial were 18 and older. They had to have an acute ischemic stroke. They also had to have been within the 4.5-hour window. They should not have any baseline blood, blood disorders, because again, that can increase the risk of them having complications after getting tpA. And the ECAS-3, on the other hand, patients could be up to 80 years, symptoms, greater than 30 minutes. And then like the NI stroke scale, of course, if you had one that was over 25, you were excluded in that. If you had a prior history of a stroke or diabetes, you couldn't get that. And then oral anticoagulants, seizure onset, and the blood pressure had to be within goal. So I also then mentioned Alteplase. So TNK is a newer agent that I would say that within the last 4 years, most people are shifting from Alteplase to Alteplase. And so the shift again occurred after the study was conducted. And essentially the study just showed that, patients that got Alteplase, which is a more fibrin-specific agent and has a longer half-life than Alteplase, had better vascular perfusion or reperfusion, because again, remember, in an ischemic stroke, you have a blood supply occlusion. And so giving a patient Alteplase, they had better outcomes. And because of that, most hospitals are transitioning from patients getting tpA to Alteplase. And so this is a nice chart that compares both of them. Outside of them, again, I mentioned tpA is an older agent. It binds semi-selectively to fibrin, but Alteplase is more specific. It's more resistant to any degradation from outside sources. The half-life is longer than tpA. In regards to preparation, which pharmacy gets involved in, nursing gets involved in, Alteplase is actually quicker. So again, you don't have to have any IV placements for with TNK, because you actually give the patient just one dose, one bolus, as opposed to tpA, where you give two administrations, a bolus as well as an infusion. Excuse me. So again, TNK is faster, more specific, and I think it may be cheaper, I'm not sure. But so again, I say that because if you work with an older attending, they may be used to tpA, but your newer attendings know TNK. So with us being new residents or providers, remember that where you work at, they may have either of the two, but both are equally efficacious. But TNK has been shown to just have better outcomes compared to Alteplase or tpA. And here is just, again, I wanted to highlight the absolute contraindications. So with contraindications, you have relative, you have absolute. With tpA, things that you cannot allow if a patient has. So if a patient has a previous, GI bleed or internal bleeding of some sort, they're not the best candidates. If they've got low platelets, less than 10,000 or 100,000, sorry, they're not the best, because again, they're gonna bleed out. If they were on warfarin and their goal INR is 2 to 3, a point of care check should be done, and that will show you that, show you the INR. If it's therapeutic, they should not be on tpA. Any head traumas, any prior strokes within 3 months excludes them as well. So I mentioned because I feel like, sometimes people do not spend as much time looking at this and they focus more on, the window, they've been here, within 3.5 hours or 3 hours, we can give them. But you need to make sure you look at all the other things that can exclude them. And the blood pressure is so crucial. Knowing what your options are to correct a blood pressure that's not within the goal before tpA is important to know. So blood pressure management, I mentioned here, you've got your goals before you get tpA, so less than 220/120. And then after the given tpA or tenecteplase, the goals modify to less than 185 or 110 or 185 or 180/105. And if you have a subarachnoid versus intracranial, that also varies. And the idea is that your blood pressure indirectly affects your directly affects your mean arterial pressure, which affects your cerebral perfusion pressure. So we are using our blood pressure to control for pressures going to the brain. And so it's important that we have our nurses keep a closer eye on this while the patient is in their care, because that can be a sign of other things not going well. So here's just a quick summary of a stroke workflow for your reference. So as I mentioned, possible stroke, coming within 20 minutes to a stroke certified center. Ideally, you want to get a stat CT scan, determine if it's a bleeding or a non-bleeding stroke. If it is a non-bleeding stroke, you want to also see if they meet criteria for ECAS-3 or NINS trial. Based on either of the two, get your NI stroke skill score. Patient can either get a thrombectomy or get, tpA or tenecteplase. And regardless of whatever option is implemented, they will end up in the neuro ICU for closer monitoring. And so within 24 hours post thrombolytic administration, there are a couple of things that you want to be mindful of. Again, the key thing here is that post tpA patient can go through complications, a decline in neuro exam, a suspicion in the patient having intracranial hemorrhage. And here you call that patient going through hemorrhagic conversion. So going from an ischemic to hemorrhagic stroke. So you have the patient neuro ICU because you want hourly neuro checks done. You want the blood pressure monitoring done very closely. You want to make sure that, you do a stat 24-hour post MRI imaging studies done to see, if there've been any changes, hold any blood thinners, do a bedside speech and swallow eval if needed, and also work with your caseworker to think of your rehab options thereafter. So that was background information about just, tpA management in the acute stroke setting or tenecteplase usage. And so now I'm going to talk about the case that I dealt with a couple of weeks ago. So the chief complaint with this patient was eye problems. The patient reports with floaters in her right eye at the hospital, in the ED actually, in a level 3 sister hospital, but she had no idea when this began. So the HPI was 69-year-old Caucasian female with acute stroke-like symptoms. The patient had pain in her left hip and she has been having vision change in her right eye. And the husband called it floaters. She called it floaters. She denies any other weaknesses or trouble speaking during this time. The husband mentioned that the patient had a left-sided stroke in 2017. And then in June of 2023, they had other vascular anomalies that led to her being paralyzed. And when she actually came in, she was in a wheelchair. Surgery had been done and therapy had been done to attempt rectifying the issue, but she was in a wheelchair regardless. So patient was actually been doing home health care ever since then. And essentially her day revolved around her being at home, helping with her grandkids here and there, but she wasn't able to work. She had to get full assistance from her husband. And so again, she was in her wheelchair. 1 week prior to admission, she was normal and was standing strong, or was using the wheelchair, as I said. This week he mentioned that she became a little weaker and they thought maybe it was a UTI. The lab results showed no UTI, but then this morning, before everything happened with her having blurred vision in her right eye, she was eating okay, didn't take any medications, what they said. Then in the afternoon at about 5:30 p.m., the husband noticed that she couldn't see out of both her eyes. She said it was all dark. So the last known wall time was 17:30. Bilateral vision loss was mentioned. And then the husband also mentioned that patient was on Alteplase, which is a blood thinner, but he wasn't sure but nothing was mentioned in the ED notes about the last dose or the last night the patient took the medication. So there was some, uncertainty about medication administration as well as the last known wall time, sort of. So anyways, patient's past medical history was significant an aortic valve disease, cerebral infarction, essential hypertension, high cholesterol, hypothyroidism, measles. She's had history of a valve replacement, bilateral tubal ligation, cardiac catheterization, tubal ligation, cyst removal. Family history was significant for heart attack with her mother and maternal grandfather also having the same issue. She was married, never smoked, and did not use any smokeless tobacco products. And her baseline vital signs when she first came in were noted here. Blood pressure was 163, wasn't high. She was afebrile. She was not tachypneic, not tachycardic. Was a little higher. SATs were 95%. And of course, I mentioned that you want to get a finger stick done. Her finger stick was 114, so her blood glucose levels were fine. So no hypoglycemic event. P exam, I have everything was fairly normal with the exception of her having diminished vision in both eyes and a dense cataract that was noted. They also noted that, she had light perception only, by the binocularly, and then she could not see motion or counted fingers when the exam was done. She had left upper extremity contracture because, again, CVA was in 2019. She was very weak and difficulty with transferring from a wheelchair to the bed. And her baseline NIH score was about 30. And imaging findings confirmed that there wasn't complete occlusion of the right cervical and intracranial internal carotid artery, no evidence of an acute large vessel occlusion at the cervical Willis. Essentially, in her right MCA was the main affected portion of the brain. So with all that I mentioned, our patient came into our sister hospital, which is a level 3 hospital at about 6 p.m. or 5 p.m., I would say. The initial exam showed that she had an ischemic stroke. She then got to Alteplase, and then she was sent to our level 1 within a few hours while she was being transported to level 1 trauma hospital, which is where I was working at. EMS mentioned that she became very nauseous and she was vomiting. She got Zofran, and then during that time, she mentioned she had a severe headache that came out of nowhere. So that was already, again, a change in her neural status, and they were concerned because she had received TNK. So then when she got to my hospital, then we did a stat, CT scan, and it showed that there was hemorrhagic conversion that occurred within 5 hours of getting, tpA or Alteplase. So with the patient going through a conversion from a non-bleeding to a bleeding stroke within at most 6 hours of getting, TNK, it makes you wonder, did they truly meet criteria to receive this medication? And so that is really why, I felt like this is a very good, topic to talk about, because in my opinion, I don't think that she met criteria. I feel that, there was a lot of uncertainty about, again, her last known wall time. And then also I felt that, this patient, a thorough med rec was not done. We knew she was an because but nobody ever did enough work to see when she last took it, because after speaking with the husband, he later on said that she got her dose like within 24 hours. And with that information, she should never have been a candidate for TNK. And I think that should have had better outcomes, because she ended up actually going to our neuro ICU. And I think that she was intubated and prognosis was not very good. So again, I'm not a physician yet, but based on what I've learned so far about how you care for these patients, I don't think that there's enough evidence to support this patient receiving Alteplase or a thrombolytic agent. So I think that it's important that as future practitioners, knowing that with these patients, time is of essence, of course, but choosing the right patients to avoid poor outcomes, such as what we just saw, is essential. We have evidence-based medicine that's implemented to use as a guide. It's not, this medicine is not black or white, as I tell people. And so you use them as a guide and you make the best choice for your patient. Frequent neuro checks is essential in this patient, and an ICU, preferably neuro ICU, is important in a stroke certified center. And again, hemorrhagic conversion is so crucial, especially in the first 24 hours. So you want to make sure that you look at everything from, are they nauseous? Are they having a new headache? Have you seen a spike in the blood pressure? Don't just correct it. Think of why this is happening and let your attending or your provider know. And obviously making sure neurosurgery is close by in case of any interventions that are needed. I want to thank you guys for listening to me. And that concludes my presentation. Thank you.